Thank you, Anasal, and thank you, Ajay. To answer this question, treatment outcome and survival NCC, does the etiology matter? SCC develops in diseased liver, that we know, whether cirrhotic or non-cirrhotic, doesn't matter. And diseased liver has its own problem of liver-related outcomes besides liver cancer. So, obviously, removing etiology of a patient who has liver cancer in a background of disease is important. For example, hepatitis B or hepatitis C or alcohol, we withdraw, liver-related outcomes improves. But that's not the question. Question here is whether treatment outcomes of SCC, which is based on BCLC staging and burden of the disease, here does the etiology matters? That is the question. So coming to that, we obviously told the treatment of etiology improved liver disease status, particularly decompensation, which is the important variable of outcome, because you treat SCC and fellow dies of a decompensated liver disease. Even we know it very well. Even early SCC and intermediate SCC, many of which are downstaged and subjected to curative treatment. If you don't treat etiology, there is more recurrence and there is decreased recurrence-free survival, and there are multiple studies showing this. But there the basic question which was asked, the treatment allocation and their impact on outcome, does etiology influence this? Till date, we had decided the treatment allocation and outcome based on BCLC staging, and etiology was not coming there at all. You see, in early HCC, you subject them to treatment with curative intent. Intermediate HCC, we know the treatment, and advanced HCC, obviously, now the treatment has increased to systemic chemotherapy. Even systemic chemotherapy is being offered to those with treatment stage migration and untreated progression, about which you all know. So if you see, etiology doesn't come anywhere in treatment allocation, outcome, and prognosis. So with this, irrespective of etiology, early treatment or early HCC with a curative treatment has a good 5-year survival, whereas intermediate HCC or advanced HCC, the median survival is gradually increasing with advancement of treatment, particularly with immunocheckpoint inhibitors. Now, this is the problem. HCC microenvironment over a period of time has been studied and has been found to be an important determinant of disease progression and disease aggressiveness. And most important is that HCC per se has properties to evade immune surveillance. We know that by PD-1 and PD-1 ligand expression, for which we have developed monoclonal antibody, which you call immune therapy or immune checkpoint inhibitor. We also know, we know about these things. We also know that vascular endothelial growth factor, which we thought is necessary for angiogenesis, has been identified is another important factor to evade immune surveillance, in particularly HCC. And various basic work has shown it inhibits or it assists immune or undergoes immune evasion by various mechanisms. Therefore, we found that basic first treatment which was very successful and clear, that is anti-PD-1 and anti-VEGF, which has been cleared, and you are using atezolizumab, which is very popular now. And then why is this question? Why etiology important? Because these studies which have used immune checkpoint inhibitor, before that the standard of care was TKIs, tyrosine kinase inhibitor, like sorafenib and lenvatinib. So these studies which used immune checkpoint inhibitor no more used placebo as a control, used TKI as the control arm. So this randomized control trial, by now many, compared TKIs with immune checkpoint inhibitors, and some of the initial analysis found patient who had fatty liver disease cancer responded poorly to immune checkpoint inhibitors in comparison to those who has viral hepatitis SCC. Remember, advanced SCC is a large proportion of our patients. BCLC-C, BCLC-B, which is not responding to classical tests, and now this is a large proportion are undergoing. And we have seen in our country also, fatty liver disease associated liver cancer is becoming more and more frequent and become important cause. Two multicentric studies has already documented. So is it true? Is TKI better in mass SCC and ICI or immune checkpoint is better in viral associated SCC? We don't have biomarker which can guide us treatment in any of these conditions. So what is the rationale of this? These are based on certain retrospective studies. The confusion started with these two studies which are published in 2021 in Nature, which showed in animal models as well as human that T cell activation may have a role in NASH pathology. T cells are already active in mass. You give immune checkpoint inhibitor, these T cells will be further, there will further liver damage. And that is a big problem. These two studies, which was published 3 years back, showed. This is the first study. This study I quoted because this study included animal models of mass SCC, human models of human patients of mass SCC, and also analyze their CD8, PD1 and their activation. This is the first part of this study. In the first part, they developed mice models of fatty liver disease by giving diet, normal diet, choline deficient, high fat diet, this is high fat diet and mistake typing, and Western diet with high trans fat. These two groups resulted in fatty liver over 10 weeks. And then their liver was evaluated. They found in both this group, the frequency of CD8 cell and PD1 expression is quite high. And ideally, if this is so, anti-PD1 should work. But they continue to give them these diets, and after 13 months, they develop liver cancer in about 70% of patients. After that, they gave them anti-PD1. Those who received anti-PD1, they are more aggressive tumors in comparison to controls who were not given. And they showed this liver tumor. So, this is just opposite what was initially thought. This was very interesting. And then they did RNA-seq of the CD8 and transcriptomic analysis. They found the CD8 are active and they produce inflammatory cytokines. So they thought by giving immune checkpoint inhibitors, you are making this CD8 cell more active and they are causing more liver damage, causing more liver cancer by causing more genetic changes. This is a problem. And then they thought, let us deplete this patient, mice mass, with CD8 T cell and see whether they are improving. In fact, they documented they improved and they are less SCC. And they co-depleted CD8 and NK. NK cells are more predominant in the liver. They found similar expression. Then they analyzed the gene expression signature of CD8 cells from this model and human patients with NASH. And they have similar gene expression. They went on to analyze meta-analysis in the same study. Checkmate, you remember, is the trial for nivolumab, keynote pembrolizumab, and IMBRAVE atezolizumab and bevacizumab, you know. And they showed in human, the response in viral SCC with immune checkpoint inhibitor was significantly higher than mass SCC. And the same thing was seen when they dissected according to the etiology. And the difference of hazard risk reduction in viral hepatitis was by 20 to 30% more than MAS. And they further went ahead and took cohorts further and found similar thing, that viral SCC, well, indeed, responded much better way than the non-viral or fatty liver disease SCC. And to add this confusion, this study was published last year. And that is the Italian multicentric study which used lenvatinib in advanced SCC. And if you see, they contain both MAS patient and viral hepatitis patient. This is a retrospective study. This is the problem. And they were all advanced SCC, BCLC B and C, and see the survival. This is MAS SCC, the fatty liver disease SCC, where median survival was overall survival was 21, whereas viral was 15. Immune checkpoint inhibitor responded better in viral. Tyrosine kinase inhibitor responded better in non-viral. This was started creating confusion. Now this is the famous IMBRAVE trial which you all know, but which included both hepatitis B, C and MAS SCC. When they are further analyzed, which was only published last year, there is no difference, neither in progression-free survival nor in overall survival. The objective response rate was not different. Time to progression for liver cancer which was followed up was also not different. And this is the first FDA cleared immune checkpoint inhibitor with anti-VEGF which was used, and this is the result. We also know this about this trial, IMBRAVE 050 trial, which was published last year, where following curative therapy after surgery or ablation in early HCC, we know 5-year survival is 75%, but there is recurrence of 70% in this group of patients. The prevention of recurrence was a challenge, and till now adjuvant therapy had not helped. The first treatment therapy where atezolizumab versus surveillance and treatment showed indeed atezolizumab is very helpful in reducing recurrence rate over a median follow-up period of 7.4%. And the recurrence rate was significantly different between two groups. But when they subsequently analyze an individual etiology in this group, there is no difference, significant difference. If you see, MAS SCC has better response than HBV-SC or HCV-SC, even though they were not significant. So there is confusion, and this is a real world multicentric study where equal number of hepatitis B, C, NAS and others were evaluated. And if you see overall survival, right, is same following immune checkpoint inhibitor. Time to progression was same in individual groups and viral versus non-viral. If you see the disease control rate also following immunotherapy was similar in viral hepatitis and fatty liver disease, liver cancer. There was no difference. And when they evaluated the prognostic factor influence the outcome, they didn't find etiology at all is important. They found the standard previously described factor like alpha fetoprotein or ALB score or BCLC staging were important prognostic outcome. So there is no difference. Etiology didn't matter. It was the SCC burden, SCC characteristic which was important for determining the outcome. And even the second line therapy treatment didn't make any difference. And this is the all meta-analysis, all immune checkpoint inhibitor meta-analysis. And if you see for hepatitis B, reduction of mortality using immune checkpoint inhibitor is 30%. Hazard risk is 0.70 with ICIs. For hepatitis C, hazard risk is similar, 0.78. But for MAS, the hazard risk is 0.87. There is a 10% difference. But this difference, these are all retrospective meta-analysis. This is not prospective study. So there might be a factor or role of TKI more effective in MAS, HCC, and immune checkpoint inhibitor more in viral hepatitis. However, the rider is they are all retrospective analysis. This research question was not designed and neither was addressed in any of the study. It was a subsequent thought based on these previous two Nature papers, which showed in animal study that immune checkpoint inhibitor accelerated tumor growth. So the problem is this, and therefore I asked Salivar to analyze our own Indian data. And at AIMS, we had 67 patients we have treated with immune checkpoint inhibitors. We didn't find response as per etiology was not appreciated. Even though it's small number, the hazard risk across the etiology were exactly similar. We didn't find in real life. You saw all the previous real life retrospective analysis didn't make any difference. But the basic studies showed it. So in summary, I will say animal studies documented increased and aberrant T cell activity in MAS and MAS SCC. The MAS SCC increased subsequent to use of immune checkpoint inhibitor in this animal with increased CD8 T cell and also their transcriptomy as well as their inflammatory activity. The T cell transcriptomic revealed more production of inflammatory cytokine as well as NK cells, resulting more necrosis, fibrosis, and HCC aggravation. These mice T cell had same genomic signature as human NAS CD8 T cell. Anti-PD-1 therapy aggravated the HCC in mice model. However, in human, the data whether ICA is better than viral HCC, then in fatty liver disease HCC is absolutely unclear. Therefore, we need now stratified, prospective, randomized controlled trial using both tyrosine kinase inhibitor as control and immune checkpoint inhibitors at the test in a stratified fashion to answer this question, what is good for which group of patients? Thank you.